Picture a scenario where the improbable comes to pass, a tale of an extraordinary pregnancy that transcends medical norms and defies the odds. This tale is a case of BC, a 35-year-old married housewife from Tugbok, Davao City who came in due to labor pains. 6 hours prior to admission, the patient noted onset of labor pains not associated with watery vaginal discharge or vaginal bleeding. No other symptoms were noted. Persistence prompted consultation and subsequent admission. The patient has been a known case of Mullerian anomaly since 2017. In the same year, she was also diagnosed with peripartum cardiomyopathy with a left ventricular thrombus. She was referred to an adult cardiologist where she was maintained on unrecalled anticoagulant therapy for a year. Thereafter, 2D echo was done, which revealed resolution of the thrombus. The rest of the past medical, as well as the family history, was unremarkable. The patient is a gravida 3 para 1 1011 who had her first pregnancy in 2014, which resulted in an abortion. Completion and curettage was done and no complications were noted. Her second pregnancy in 2017 was carried to term. She delivered a live baby boy by primary cesarean section for cephalopelvic disproportion. She was subsequently advised to undergo bilateral tubal ligation. However, the patient refused since she has not completed her desired family size. The patient was made well aware of the risks during this time. After 4 long years of trying to conceive, the patient had her third pregnancy in May this year. The pregnancy progressed without complications and the fetus developed normally. The gynecologic history of our patient is unremarkable except for cyclic dysmenorrhea. The personal and social history, as well as the review of systems, showed unremarkable findings. The patient arrived at the emergency department ambulatory with the following vital signs. The physical examination are as follows. Focusing on the abdominal examination, the patient had a gravid abdomen with a visible post-operative scar and a well-defined linea nigra. The fundic height was measured at 32 centimeters and the fetal heart tone was measured at 136 beats per minute, appreciated on the maternal left side. Lubbold's maneuver was also performed, confirming a cephalic presentation. The patient has grossly normal external genitalia. On bimanual examination, the introitus admits 2 fingers with ease. However, we noted a longitudinal, non-obstructing vaginal septum dividing the vagina into 2 cavities. The patient has 2 uneffaced cervix, where the right admits the tip of the examining finger. There were no adnexal masses or tenderness noted. Upon admission, baseline laboratory tests were ordered and it showed unremarkable findings. We now arrive into the salient features of our case. Combining all this clinical information, we came up with the following differential diagnosis. First, we considered septate uterus as it is the most common Mullerian anomaly encountered in clinical practice. This was considered due to the following features. However, the patient presented with cyclic dysmenorrhea, which would make this diagnosis less likely. Another differential we considered is bicornuate uterus. This was considered due to the following. However, the patient did not have any of the following symptoms. Therefore, we make this diagnosis less likely. That being so, we considered didelphys uterus, giving us our admitting diagnosis, gravida 3 para 1 1011, pregnancy uterine, didelphys 40 weeks age of gestation by late ultrasound, cephalic and latent phase of labor, Mullerian anomaly, uterine didelphys, advanced maternal age, status post-cesarean section 1 for cephalopelvic disproportion, 2017 Spmc. The patient's stay at the labor room was uneventful. The plan is for repeat cesarean section with bilateral tubal ligation. Intraoperatively, evidence of didelphys uterus was seen as shown in the image. The patient successfully delivered a term live birth baby boy with the following birth outcome. The surgeon then proceeded with bilateral tubal ligation. The patient's post-operative period was satisfactory and she was subsequently discharged as a case of Gravida 3 Para 2, 2012, pregnancy uterine, delivered term, cephalic, live birth baby boy, large for gestational age, Mullerian anomaly, uterine didelphys, by repeat low segment transverse cesarean section for scarred uterus, advanced maternal age, status post cesarean section 1 for cephalopelvic disproportion 2017 Spmc, family planning acceptor, bilateral tubal ligation. Didelphys uterus is one of the rarest Mullerian anomalies. With this anomaly, there is an increased risk of having spontaneous abortion, difficulty in conception, and a very low chance of carrying a pregnancy to term in comparison to a normal uterus. In this case, we noted history of cyclic dysmenorrhea, pregnancy loss, and difficulty in conception, which can all be explained by her uterine anomaly. For diagnostic evaluation, MRI is the gold standard. However, 3D ultrasound has been considered to be equivalent in most circumstances. Surgical intervention is indicated for women with the following. In the case presented, the patient did not have any of the following, hence, no other surgical intervention was done. In a recap, we presented to you a case of a 35-year-old Gravida 3 Para 2 2012 who successfully carried and delivered 2 healthy and full-term pregnancies despite having a didelphys uterus. Within the intricate tapestry of medical anomalies, this case stands as a striking testament to the profound mysteries of human biology. Against all odds, the improbable has come to pass. Thank you.
Thank you.